Good evening. My name is Kirk Mills. We'll be talking about the eyeball today, okay? We're going to be talking about some really common issues that the eyeball can have, and I try to pick some issues that I think we'll see a lot as nurses. So, without further ado, let's get into what the eyeball does, how it works, better understand help us better to understand the disease processes. Here's my crappy diagram. I apologize. I barely have good writing, so I'm not a very good artist, but we'll make it work. Light gets shine to your eye. It originally goes in through the cornea, gets refracted to the lens of the eye. The lens then refracts it upside down. Interestingly enough, the image is upside down at this point. Hits the retina. The retina is a very important part of the eye, if not one of the most important parts of the eye. This is what actually creates the signal. The retina, the yellow part here, creates the signal that can travel through the optic nerve to the brain. Once it gets to the brain creates it into an image that we can see. But, like I said, that image is originally upside down. So, the brain actually flips it, so the world is right side up. Very interesting stuff. All right, so let's talk about the retina, because if that gets detached, we can have some serious issues. So as we said, the retina is the membrane in the back of the eye here that light hits it, passes through the eye, and it focuses the image from the lens onto the retina, creates the signals to the eye. So when the detachment occurs, it can really cause some issues. And some symptoms of this would be blurred vision, obviously, partial vision loss. Kind of feels like a curtain is pulled over your eye. You might look to the side and see a bunch of like really bright lights out of nowhere for some reason, like someone's taking your picture. You can suddenly see floaters. We've all seen floaters before, but it can be like really intense. If if it can be really intense if the retina gets detached, because there's a lot of stuff that can get in there, and I think pieces of the retina can be floating around. So there's different types I want to talk about real quick. The first one is regmatogenous retinal detachment. That's kind of the trauma related one. So that's when your let's go back to the diagram. That's when your retina gets detached here, the fluid gets under the retina, and the retina starts to pull away like carpet, like kind of pulling up carpet. So that can be very dangerous. And once it gets pulled away from where it needs to be, there's not oxygen, nutrients being supplied to the retina anymore, so that can cause more issues. Tractional retinal detachment is another one that can be caused because there's scar tissue starting to form on the retina, and it causes it to contract. Scar tissue is really tight and less elastic, so it kind of pulls, and then as it's pulling and becoming scarred, it kind of pulls up from where it needs to be. Again, like carpet. And as we know, diabetes mellitus can really cause vascular issues, and it's no different with the eyeball. It can cause vascular issues with the eyeball, and that means the retina is not getting the nutrients and the blood flow it needs. That's causing the scar tissue. So, last one is exudative detachment. This will go back to the diagram. It's kind of like an inflammation of the retina for some reason, and it causes it to expand and pull away. And then there can also be a tumor that grows here and also pushes the retina away from where it needs to be. And there's also something called Coates disease. Coates disease is when there's an abnormal development of blood vessels that are kind of like leak proteins that build up behind your retina. And again, just another thing pushing the retina, the yellow part here, away from where it needs to be. So who's at risk for retinal detachment? People who play sports, obviously, get your eye hit or get boxed, boom, detach that retina. I'm sure you've heard in movies of people getting there. People being over 50, it can also run in the family, believe it or not. So that's interesting. Like I said, diabetes mellitus, so try to control that so those blood vessels will supply good nutrients to the area. Treating the retinal detachment was really interesting. There's actually a lot of different treatment options. One was photocoagulation. And what it does is a laser kind of gets shot into your eyeball and cauterizes the retina back into place. So that was cool. There's another one called cryotherapy, which it kind of puts a really freezy device, freezing probe on the eyeball, freezing this retina back to where it needs to be. So that's interesting that they can either use very hot or very cold measures. There's also another one that's called which one? So there's one, I can't remember where I saw it, but they actually put a gas bubble into your eye. I think it's called a virectomy. They put a gas bubble into your eye and kind of inflating the eye will kind of push that retina back to where it needs to be. Obviously, that's done with a lot of anesthesia and stuff, so that would be like a kind of a major procedure. So there's also one called scleral buckling. Scleral buckling is where they kind of put a rubber band around your eye to kind of boop, kind of just pushes the eye, back like this. Kind of makes it everything where it needs to be, like tighter, like a bladder sling or what have you. But for the eye, just boop, pushes everything where it needs to be, and it'll kind of compress the eye onto the retina, and allowing it to heal because it's pushed back where it needs to be. So pretty interesting things that they'll be able to do. And then kind of how they diagnose it. I think one of the most obvious ones is they use an ophthalmoscope. We've actually used these during our physical examinations. So the light from the ophthalmoscope goes in, lights up this area, and we can see the retina. We can see if there's any tears. So pretty interesting. But okay, next, just for the sake of time, we'll keep moving. Next, we're going to do macular degeneration. That one kind of hits home for me because my grandmother has it, so I think I might be having it. So I'm glad I'm kind of reading up on this. I can, maybe get myself treated and make sure that I don't lose my eyesight. We kind of need that to be a nurse, don't we? All right, age-related macular degeneration, or just macular degeneration. So common eye disorder seen in a lot of Americans. My grandma has it for, like I said, but she's 95, so luckily it didn't affect her. So this eye thing, actually, your central vision is actually affected. I'll tell you why. Right here, your macula is part of your retina, and we discussed how important that retina is, how it creates that image and the signals. So this macula is really it really makes your vision sharp and focused in the central vision, not really the peripheral, but the central vision. It really helps with that. So it can really screw up your central vision. You'll be able to see outside of your eyes, but boom, right where you need to see can really be some issues. And there's two versions of it. It's called dry and wet. Dry, try to give you the Spark Notes version here for time. Dry is when there is some yellow stuff. It's called drusen. Drusen is built like a yellow plaque type stuff that builds up behind the macula, causing some image disturbances. Wet macular degeneration is when there's some blood vessels that build up back here, kind of leak, also causing a disturbance and creating the signals in the image that need to go to the brain. So those are the two types. Again, there's obviously going to be issues with your vision, reduction in central vision, like I said, not really the peripherals, but the size. You can have trouble distinguishing lines. Like there'll be lines, but they won't seem straight. They'll be kind of wiggly, so it's really hard to read numbers and stuff like that. Need for brighter lighting. You really can't see at night. Like you really can't see in the dark. Your eyes have trouble adjusting. You start to have trouble recognizing faces, which can be scary. So this one's a pretty serious disease, and so recognize the symptoms so you can go get treatment. What little treatment there is. So, all right. How do we diagnose this? Well, two things. Again, they'll use the ophthalmoscope to kind of look in there. There'll be another. Amster. Sorry, I couldn't remember the name. Amster grid test. The Amster grid test is where there's a grid, there's a bunch of lines, there's a dot in the middle. They'll have you look at the central part of the grid. If those lines are all squiggly and stuff like that, like I said, the lines will be you won't be able to see them very well, and they'll be squiggly. That kind of means that your central vision might be off, and then you might have an issue. fluorescein test. Like I said, they'll use an ophthalmoscope, but first they'll shoot some fluorescein up. Actually goes in the vein of your arm, eventually travels to your eye. Fluorescein lights up those blood vessels, and they'll see if those are leaking behind the macula, causing those central vision disturbances, because the blood behind the macula from the blood vessels that are leaking can really disturb those signals. Um, so a couple other things I wanted to talk about. It's a family thing, but there's it's a genetic thing. I meant to say, but there's some other things that you really need to that you can do to decrease your chances. You can stop smoking. You can eat healthy, exercise. Being overweight really increases your chances. Cardiovascular disease does. High cholesterol does as well. Yeah, but being over the age of 55 is the biggest factor, and sometimes you just can't avoid it because, like I said, it's just you have a family history of it. Um, so treatment-wise, there's a couple medications that they can inject for wet macular degeneration, and what it does is it kind of shrinks those blood vessels behind there that's causing the image disturbances. Um, those are actually like injections into your eyeball. There's other medication or for dry macular degeneration, not a lot they can do. I think there's some surgical options, but unfortunately, sometimes the doctor will think that's too risky, and you kind of just have to work with an eye therapist, kind of like a speech therapist, but an eye therapist. They kind of just help you make the best of your vision and things you can do to increase your vision. And for my grandma personally, it's been very hard for her. She even sends me these bigger checks than normal because she can't see, so she has to have these big checks, and they kind of look fake, but they're big, huge ones, so she can see better. So this just shows you how bad your eyesight can be. So, all right, well, so yeah, that goes over treatment options. There's one more thing that actually I saw it in my research here that she actually experienced, and you can actually this one can give macular degeneration can make you experience hallucinations, not because you're crazy, not because you're under the influence of something, but your eye vision is so bad that the signal that is interrupted behind the macula, your brain can try to compensate for that and actually create a image that's not there. That happened to my grandma. She was sleeping. She woke up because she was about to go to the bathroom, and suddenly she saw a man's face at the edge of her bed. And the man's face was looking straight at her, and then suddenly it just evaporated into midair. And what happened is her eyes were kind of creating um, her brain was creating an image that wasn't there, but it was trying to compensate because it couldn't really see. So, very interesting stuff. There's also ways you can take a bunch of vitamins. You can talk to your doctor, because me personally, I would want to do anything I can to make sure to stop this disease um, from getting any worse than it can. So there's uh, some vitamins you can take that can reduce the long-term effects by 5 years, kind of slow it down. Like I said, those treatments aren't really cures, but they can slow down the progression of this disease. So you can talk to your doctor about vitamins. Some vitamins you can take are vitamin C, vitamin E, some zinc, beta carotene, some copper. This is based on a study in 2001. Just really helps slow the disease, and it helped reduce the loss of vision by 19% of people that actually tried it. So, I would try whatever I could to keep macular degeneration from getting any worse. So, all right, last but not least, we're going to go to glaucoma. So I'll be back in just a second. We'll go over that. Okay, we are back. Got my diagram here. Last one I want to talk to you about is glaucoma. It's a very common one, actually. So there's aqueous fluid in the eyeball, and this aqueous fluid can kind of build up and create a lot of pressure in your eye, and that pressure over time actually starts to erode your optic nerve, so you're not able to send signals to your brain anymore. So that can really, really screw up your vision. There's obviously it affects your eyesight, but this one's got some different signs and symptoms. You can become nausea, vomiting, redness in your eyes, sudden vision changes, seeing color, rings around lights, very a lot of eye pain. What causes glaucoma is the aqueous humor. Usually it gets made and then it can kind of seep out through little passages, but sometimes these passages will get blocked in your eye, these channels. They're mostly in the cornea and the iris. These channels kind of allow the fluid to balance out through the eye. So if those get blocked, your intraocular pressure will build up. It's like overinflated eye, and it'll damage your optic nerve because of the pressure exerted on that. So some causes of this are dilating eye drops. Like I said, those blocked drains, medications, corticosteroids. People take that for asthma and breathing and stuff like that. Reduced blood flow through your optic nerve, high blood pressure as well. So, and that's how the doctor will. That's kind of how the doctor will diagnose. They'll look at your family history, your medical history, and actually your ethnicity and your age can kind of make it more higher chances of you getting it. Ethnicity: African American people or people of African descent have higher risk than Caucasians. People of Asian descent actually do too. So, yeah, they'll diagnose it through looking at your medical history, stuff like that. But the most important diagnosis, I've seen them do this in the ER. It's called the tonometry pen. We just call it the tono pen at work for short. So I'll show you a picture of that. The tono pen looks like this, kind of cool. And there's a cover that goes on this part. It's like a little condom thing that goes on this part to make sure that we don't pass any germs around. So that's pretty cool. And we press it against the eyeball, and what it does is measure how much the eyeball pushes back. So, and then it'll read on that little thing there. It'll read on there how high your intraocular pressure is. So that's pretty cool. How it's treated: you can do some medications. There's some eye drops or pills, and that can kind of get that fluid out of there. Sometimes they'll need surgery. If the surgery will create little channels, like I said, if those channels are blocked to make the intraocular fluid, the aqueous humor, it can kind of make some holes to get that out of out of the eyeball to lower the intraocular pressure. So there's different types. I think I forgot to go over the different types, but there's congenital glaucoma. Like I said, it can kind of just be in children, and maybe I haven't really seen this, but maybe the corticosteroids that were used as when they were younger to develop their lungs as a fetus, maybe that can have something to do with it. There's a angle closure acute glaucoma. That's a very dangerous one. It's when the fluid suddenly becomes blocked, and this is like intense eye pain all of a sudden. It's quick, it's severe. That's when the fluid is just rapidly making those eyeballs swell, and so severe pain, nausea, blurred vision. Go to the ER immediately. Open angle glaucoma, chronic, is kind of a slower onset. Chronic, as we know, there's a key word there. Slower onset, but it can cause the eye you just kind of lose your vision over time. So that's kind of a sneakier one. But so yeah, those are some things of how it's diagnosed, and like I say, you can treat it through medication and surgery. There's no cure, and it can't be prevented. It happens sometimes, just like any other disease. The best way is just get an eye appointment yearly, get it checked up, so make sure that chronic version of this disease isn't creeping up on you. And yeah, just kind of get your eyes checked, and make sure that if there is a problem, that you can get it corrected with your doctor, get on the medication to make sure that optic nerve, like we said, the optic nerve, make sure that's not getting eroded and too much pressure built up against it. So, okay, well, I know I'm over the allotted time, but there's a lot of stuff going on in the eyeball. It's a very complex organ. So I hope you enjoyed my video today. I hope I didn't go too fast. I was trying to get everything covered within a allotted time. Really appreciate it, and thank you for listening.